So we're going to talk about copper deficiency in neuro-ophthalmology, and even though this is uncommon from the intake side, the way this presents to us is on the absorption side. However, you do need to think about it in eating disorders, patients with atrophic gastritis, stomach surgeries of various types, and the prototype is the bariatric surgery. And you should know that there are two types of bariatric surgery. There's the restrictive types, which are like the gastric sleeve procedure and the adjustable gastric band procedure, and the absorptive procedures. And the absorptive procedures are the bypass procedures, either the Roux-en-Y or the biliary pancreatic diversion procedure with the duodenal switch. So those procedures are actually sometimes both, where they're restrictive, making the stomach smaller, and a bypass. And because the copper is absorbed in the duodenum, that means the Roux-en-Y and the duodenal switch procedures are much more likely to produce the copper deficiency. The way it comes to us is as a nutritional optic neuropathy. And as you'd expect with any optic neuropathy, the chief complaint is going to be afferent complaints, loss of vision. It's going to be central vision, either central or cecocentral scotoma. And in the beginning, the optic nerve may appear normal, but over time, temporal pallor in the papillomacular bundle will develop. And on OCT, we might be able to see that decrease in nerve fiber layer in the papillomacular bundle. And so we'd like to treat the patient before we develop the optic atrophy. So it can be acute, subacute, or chronic. It's painless, bilateral, usually symmetric, central scotoma, 2100, 2200 level of vision. Optic neuropathy, nerve is normal initially, but might have a little bit of hyperemia or swelling, and then nerve turns pale over time, optic atrophy. The treatment, of course, is to make the diagnosis first, which is checking the copper levels as well as ceruloplasmin and the 24-hour urinary copper. And we have to check the zinc and the iron, because excesses of zinc can actually impair the absorption of the copper as well, as can iron. So too much of zinc and iron can worsen too little of copper. And then the treatment is to give the copper, either parenteral copper, intravenous, and the dosage has not been evidence-based established, but something on the order of 2 to 8 milligrams per day. In the beginning, maybe high dose, like 8 milligrams, and then 6 and 4 every week, reduced by 2 milligrams until you get to the maintenance dose, 2 milligrams a day. And you have to recognize and treat the concomitant vitamin deficiencies that can occur in bariatric surgery. That's all the other vitamins, really. But if you have an optic neuropathy, in particular B12 and folate, so we're going to do the B12, folate, the methylmalonic acid, the homocysteine. You're going to test the other vitamins as well. But you really should be thinking about copper in combined mechanism, absorptive restrictive bariatric surgery patients who develop acute, subacute, or chronic and progressive nutritional optic neuropathy.